The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone. This is Güliz Barkan. I am the president-elect of the American Society of Cytopathology, and I'd like to welcome you for the weekly American Society of Cytopathology educational sessions. Today, as usual, we have a treat for you, and our guest is Dr. Martha Pitman. She is a pathologist. Actually, she doesn't need any introduction to anyone in the cytology world. She's very well known nationally and internationally. She is an international expert on pancreatic pathology, and she is the director of the cytopathology laboratory at Massachusetts General Hospital in the Harvard Medical System. And her topic will be pancreatic cysts and the approach to them. Welcome, Dr. Pitman.
Thank you, Dr. Barkan. It's such a pleasure to be here, and welcome to everyone from around the world. I hope this webinar finds you all healthy and happy as much as possible under these lockdown circumstances. So it's my pleasure to be here to share with you my experience in approaching the diagnosis of pancreatic cysts. We're going to start with the background, the foundation of the clinical and pathological features of pancreatic cysts. As Dr. Syed Ali has said, the eyes cannot see what the mind does not know. So we will certainly fill in the gaps of foundational information so that we can extrapolate what cytology means and its ancillary tests to making a preoperative diagnosis. We'll move on to the purpose of preoperative evaluation of pancreatic cysts and address the two questions our clinical colleagues want to know from FNA of pancreatic cysts. And then we'll follow up with how we answer those questions. How do we triage pancreatic cyst fluid for optimal information from that usually scant specimen? And what ancillary tests can we add to cytology? And how do we report these results so that the patients can get the care that they need? So let's start with what pancreatic cysts we're going to be addressing. This is the primary differential diagnosis. There are other cysts in the pancreas, but by and large, these are the ones you're going to be dealing with. There's the non-neoplastic pseudocyst, the benign neoplastic serous cyst, the pre-malignant mucinous cysts that have malignant potential, the mucinous cystic neoplasm and intraductal papillary mucinous neoplasm. And then there are the secondarily cystic solid tumors that can mimic primary cysts of the pancreas, primarily including neuroendocrine tumors and solid pseudopapillary neoplasms. And this cartoon illustrates the various architectural features of these cysts and how they may be reflected on imaging and what characteristics we can use to add to the puzzle of what these cysts might be for our preoperative operative diagnosis. And we will use a multimodal approach that incorporates the clinical information, including patient age and gender, the symptoms that the patient may have, and importantly, past medical history. Radiological information is really important. Where is the cyst located? And what organs were traversed to get to that cyst? What are the imaging characteristics of the cyst? What size is it? What are the contours? Is there obvious invasion? The structure of the cyst, whether it's unilocular or multilocular, the wall thin or thick. Is there calcification in the wall, or is there a nodule or mass in the wall? Is it an enhancing nodule? What did the gastroenterologist see when they aspirated that cyst? Were the contents of this cyst thick, viscous, thin, watery, clear, brown, opaque, sticky? All of those gross descriptions really add to the information we have under the microscope. And critically important are ancillary tests. CEA and amylase, the biochemical parameters of that cyst fluid, are really pivotal in helping us to make a diagnosis instead of a non-diagnostic report. Is there enough to make a cell block for immunohistochemical stains? And can we send some of that cyst fluid for molecular testing to add to our diagnosis? Even if it may not be at the time of your diagnosis, it can certainly add to the clinical impression of that cyst when it's available. So let's start with our foundation, pancreatic pseudocysts. These are non-neoplastic cysts, and almost all patients have a history of pancreatitis when they have a pancreatic pseudocyst. And in the United States, it's most often related to alcohol abuse. But pseudocysts can also occur in patients with trauma or recent history of surgery. By imaging, pseudocysts are unilocular and non-septated. So when imaging shows you a multicystic lesion, pseudocyst falls off the differential diagnosis. They are thick-walled cysts, and they do not have an associated mural nodule. So histologically, these are called pseudocysts because there's no epithelial lining. The lining of these cysts are histiocytes, inflammatory cells, mesenchymal tissue, because pseudocysts are the result of autodigestion of the pancreatic tissue. And so what you have left is inflammatory reaction to that degeneration. So that's important when we're looking at cyst contents, because when you have an epithelial cyst lining component, then pseudocyst falls off the differential diagnosis. But when you're doing an EUS FNA, you can have contamination from the gastric or duodenal tract. So you have to be able to recognize that contamination. Now, a serous cyst is a benign neoplasm. These are slow-growing lesions that generally occur in women much more than men, and usually in the 7th decade. So they're often referred to as your grandmother's cyst. They're known to be associated with von Hippel-Lindau gene, often a deletion of 3p25. Most patients are asymptomatic, but they can cause pain from hemorrhage and degeneration. Now, imaging shows a circumscribed multilobulated lesion. Most of them are microcystic with a fibrous septae or central scar, and some of them can be associated with calcifications. But these lesions can undergo a significant degeneration, leading to an oligocystic, even a unilocular variant. And so they can be confused with primary cyst of the pancreas, often mucinous cyst. And so the clinical differential is it a premalignant mucinous cyst, or could it be an oligocystic serous cystadenoma? Now, histologically, these lesions are lined by non-mucinous cuboidal epithelial cells. They're round and polygonal cells with a round regular nucleus, and the clearing in the cytoplasm is glycogen, which we can highlight with a PAS stain and prove it with a diastase that takes away the glycogen. Mucin would stay in the cytoplasm with diastase, so that helps to distinguish glycogen from mucin. Now, these lesions can become oligocystic. And you can see here the hemorrhage and the partial solid component. There's microcystic, almost solid looking. And these lesions are vascular. The septae of a serous cystadenoma is vascular with lots of capillaries, and they can bleed. There's a very high VEGF level in the septae of these cysts, and they bleed. And when something bleeds, you get a lot of hemosiderin-laden macrophages that can be in the wall, but also shed into the fluid. And because the lining of serous cystadenomas are so delicate and fragile, what you may only see in your cyst fluid are these hemosiderin-laden macrophages. And so they can act as a surrogate marker and to suggest the diagnosis in your evaluation. Now, mucinous cystic neoplasm is a premalignant neoplasm with malignant potential. Almost all of them will eventually become malignant if left in place long enough. They're almost always in women with a 20-to-1 ratio to men. And these are low-grade benign lesions for the most part. But as I said, they all have malignant potential and they can progress to malignancy. So the prognosis for these, when non-invasive, is excellent. Patients are cured, which is why almost all of these will be resected regardless of grade, since they generally occur in middle-aged women in the body and tail of the gland, such that a distal pancreatectomy is much more cost-effective and less anxiety-producing than the wakeful watching for 20 plus years of a 50-year-old wondering if her cyst is going to progress to malignancy. So that's why mucinous cystic neoplasms are going to be resected even when it's a low-grade, benign appearing cyst. And on imaging, almost all of these occur in the body and tail of the gland. And they do not communicate with the pancreatic ductal system. So if a radiologist says, I see a connection to the main pancreatic duct, it's almost never going to be a mucinous cystic neoplasm. It will be the other mucinous cyst and IPMN. Generally, these are thick-walled and loculated cysts. So again, when you see these septae showing loculations, pseudocyst falls off the differential diagnosis, and what you're left with is this a mucinous cyst or an oligocystic serous cystadenoma. Now, on histology, the key feature is this subepithelial ovarian type stroma. It's required to make a diagnosis on histology of a mucinous cystic neoplasm. Of course, we do not see this stroma in the typical FNA of a mucinous cystic neoplasm. So unless you're using some type of spy bite biopsy or microforceps biopsy that can grab a piece of the wall that contains some of this ovarian type stroma, you're not going to be able to make a specific diagnosis of a mucinous cystic neoplasm. And these lesions can have variable degrees of atypia, even in the same locule, going from benign looking low-grade epithelium to more intermediate, moderately dysplastic epithelium. And you can even have an invasive carcinoma underlying this non-malignant cyst lining. Now, the intraductal papillary mucinous neoplasm can affect the main duct. So this is called the main duct type, branch duct type, or it can involve both, where you have a dilated main pancreatic duct and often multiple cysts along the main duct, combined disease. And these are ductal lesions, premalignant ductal lesions that have various papillary mucinous epithelium. The branch duct lesions are not as villous and papillary as, say, the main duct IPMNs, and they have heterogeneous cell types and degrees of atypia. And they are not associated with that ovarian type stroma under the epithelium like mucinous cystic neoplasms. Now, there are different epithelial types of IPMNs that we do not necessarily need to specifically identify as gastric or intestinal type or pancreatobiliary type, but we do need to recognize the grade, the degree of atypia in the epithelial lining. Most gastric foveolar linings are low grade, and this is the most common lining of your branch duct IPMNs, but they do progress in degrees of atypia. They become pseudostratified to become intermediate grade, and then they become high grade, looking very much like your pancreatobiliary type. Your intestinal type sort of looks like a tubular adenoma of the colon. You have pseudostratified columnar epithelium with little mucin compartments to some of the cells, not all of the cells. And then you have your pancreatobiliary type, which by definition is high grade, very little residual cytoplasmic mucin, very high NC ratio, irregular nuclei, and they look like high grade dysplastic epithelial cells. Now, these are all premalignant cysts, but they have malignant potential. In other words, all of them can be associated with an invasive carcinoma, which is why we need to monitor them and figure out where they are in their degree of atypia and their risk for developing invasive carcinoma. Now, gastric type leads to invasive tubular carcinoma, which is the same bad prognosis as conventional ductal adenocarcinoma of the pancreas. That's why, even though these are benign, low-grade cysts in branch duct location, because they can lead to this invasive carcinoma, which has a really poor prognosis, we need to monitor these and decide when they are high risk and if they can be monitored conservatively, or do they need to be resected. Now, the intermediate grade intestinal type IPMNs are the most common type in your main duct, and they are the ones that lead to invasive colloid carcinomas. And although colloid carcinomas have a better prognosis than tubular carcinomas, they still are an invasive carcinoma. And we do want to resect these prior to the development of an invasive carcinoma. So since most main ducts have this lining, all main duct IPMNs will be resected in surgically qualified patients. And then your pancreatobiliary type lining is already a high-grade dysplastic lesion, and it too leads to invasive tubular carcinoma. So if we see this high-grade epithelial atypia, then this is an indication for surgical resection. Now, our secondarily cystic solid neoplasms, our most famous, I would say, is your solid pseudopapillary neoplasm. Again, clinical information is critical. 89% of these occur in young women with an average age of 28 years. They can occur anywhere in the gland, the head, the body, or the tail. When I was in medical school, I was taught, a solid and cystic tumor in a young woman in the tail of the pancreas is almost always going to be this lesion. It's often a board question. They may show you one high-powered field with this clinical information, and that's going to be your answer. They're secondarily cystic, and so the proportion of solid and cystic components is highly variable. They're pseudopapillary from this cystic degeneration, and so what we see are these papillary-like structures with a central vessel that often have this kind of myxoidy type stroma where the epithelial cells kind of fall off the highway of this central vessel, and they can have dramatic myxoid stroma, not so much in the image here, but it can be quite dramatic. The cells themselves are bland polygonal cells. Coffee bean nuclei is a key morphological feature. They can have these perinuclear vacuoles, and they can even have intracytoplasmic hyaline-type globules that can be quite striking, and particularly on a diff-quick stain. Now, beta-catenin mutation is present in almost all cases, and you will see that upregulation with strong nuclear staining in these lesions. Now, neuroendocrine tumors also can become cystic. About 10 to 15% of neuroendocrine tumors can become cystic. They become cystic from central necrotic degeneration, working its way to the outside, which is why one of the key features on imaging is a thick cyst wall, and this can make them confused with mucinous cystic neoplasms. Histologically, they look like typical well-differentiated neuroendocrine tumors where you can see the polygonal morphology of the individual tumor cells. You can tell they're endocrine from their coarse stippled chromatin. You can do the synaptophysin chromogranin if you have material in a cell block by biochemical testing. They will have a low amylase and CEA level in the cyst fluid, and you won't see any mutations on NGS panel. So let's go to our two questions that our clinicians want us to answer. They want to know, is the cyst mucinous or non-mucinous? And that may be all you can tell them from the information that you have at the time and from what the cytology and biochemical testing tell you. But that can be enough for that clinician to know that that patient has a premalignant mucinous cyst that needs monitoring. In contrast to a non-mucinous cyst, such as pseudocyst, that can be clinically managed or drained, or a benign serous cyst that does not necessarily need surgical resection or follow-up monitoring. So that's question number one. Then question number two, and this particularly relates to mucinous cysts, but is the cyst morphologically low grade and low risk or high grade and high risk? And we would use our ancillary tests also to help us answer that question. Because if we can distinguish mucinous on the one hand and high risk on the other hand, or high grade epithelial atypia is present in our cyst fluid, then we can stratify those cysts that need surgery. We can separate out our non-mucinous cysts from our mucinous cysts that are low grade and can be monitored conservatively from our high risk mucinous cysts and non-mucinous cysts that need surgical resection. One of the big questions that still remains is, what do we do with IPMNs with intermediate grade dysplasia? Now, I told you before, if it's present in a main duct IPMN, it will be resected. But if we see that intermediate grade gastric type dysplasia in particular, is that a surgical indication? That still needs to be answered by our clinical colleagues and research data to be determined. So our diagnosis is going to use this multimodal approach of getting patient demographics, the age, the gender, the medical history, symptoms. Do they have pancreatitis? Does the diagnosis of a pseudocyst make sense? What are the imaging features? Where is the cyst located? What is its size, its shape? Are there septations? Is the cyst wall thick? Is there a mural nodule? Does the clinical impression fit with what you're seeing under the microscope and on imaging? And what are the gross features of that cyst fluid? That can answer the first question right off the bat. Thick, sticky, white fluid, viscous fluid is a mucinous cyst. Thin, brown, clear, yellow fluid can be just about anything. But a serous cystadenoma is not going to have thick, sticky, white fluid. So this gross description can be very important and should be available in the electronic medical record under the report from your gastroenterologist. And then we want to look under the microscope. Or is what we are seeing under the microscope diagnostic, suggestive of a diagnosis? Are we seeing mucinous epithelium that we can be sure is not contamination? Are we seeing serous cells with non-mucinous cytoplasm associated with our surrogates, hemosiderin-laden macrophages that would be diagnostic of a serous cystadenoma? Are we seeing high-grade epithelial cells that would indicate a high-risk cyst warranting resection? Do we recognize these coffee bean-shaped bland nuclei with even chromatin and little wispy tags of cytoplasm that would go along with a solid pseudopapillary neoplasm? And how are ancillary tests going to add to what we see on cytology? What is the CEA level? What is the amylase level? Does it make sense with everything else that we are seeing? And down the road, genetic testing may give us information that's not present in any other part of the puzzle. Is there a KRAS mutation, GMAS mutation, von Hippel-Lindau gene? If that's present, it's going to completely disregard the clinical impression of a branch duct IPMN. Are there mutations late in the progression from adenoma to carcinoma that would add weight to maybe what you're seeing under the microscope as a high-grade epithelial lesion? And then if you have enough tissue for a cell block, or maybe you're using next generation microforceps biopsy needles to get a little tissue, that can distinguish between our branch duct IPMN from our mucinous cystic neoplasm, which shows this subepithelial ovarian type stroma. So now we're at the bedside of the patient in the EUS suite, and they're draining the cyst fluid. What do you do with that cyst fluid? Well, at MGH, we do not do rapid on-site evaluation. It's absolutely a waste of resources to take a little piece of that fluid and try to smear it on a slide. It's not going to affect what that gastroenterologist does with that cyst, because they are going to drain that cyst of as much fluid as possible. And if there's a solid component, they should be separately aspirating that solid component. And you can certainly do direct smears of that solid component aspirate. And they should always do that, because the cyst fluid may not represent the highest grade of that cyst, particularly if that solid component is an invasive carcinoma. May not be represented in the cyst fluid. So what you tell them on a rapid is not going to change that. So we don't want to waste any of that precious, often scant cyst fluid for rows. And then we want to send that fresh, undiluted cyst fluid to your lab. In the early days of our investigation of pancreatic cysts, the gastroenterologist would send an aliquot to the chemistry lab for CEA and amylase and send us an aliquot. And then the chemistry lab would spin down the cyst fluid, throw away the cells, and do their CEA and amylase. That's a waste of cells, which are often scant. So we want all of that material to come to cytology so that we can accurately, optimally triage that fluid. And then we want to do CEA and amylase. If you have the means to do molecular testing, do that. We reflex NGS testing off of our pancreatic cyst fluids. And then we take the spun down material and make a cytospin. Rarely do we have enough for a cell block. And as I said, you can make direct smears of a solid component, or you can make direct smears if the fluid is so thick that it is unable to come into a syringe like this. And at that point, you already know you're dealing with a mucinous cyst. So question number one has already been answered. So this is our triage protocol that we use. We get our fresh cyst fluid, undiluted, not put in thin preservative or SurePath preservative or RPMI, because all that does is dilute, fix, and attenuate your specimen. And you may not appreciate the background material as much. If we have enough volume, we will take an aliquot off the top of a vortex homogenized specimen and send it to our molecular lab. We have not validated cell-free DNA at this point for this, so we take an aliquot off the top so that there's a homogenized fluid. Then we take the residual fluid and we centrifuge it to make a cell button, and we make a cytospin out of that, because I want to see all of the material in the background: blood, mucus, inflammation, necrosis, everything. And then we take the supernatant of that and we send that for CEA and amylase. CEA prioritized over amylase. So these ancillary tests help us answer the question primarily if it's a mucinous cyst and occasionally if it's a serous cyst. So for example, if our CEA is 192 nanograms per mil, that is our cutoff for a mucinous cyst. This has very high specificity. There's a rare false positive in lymphoepithelial cysts, but there are a lot of false negatives, so the sensitivity is not that great. So all cysts are not necessarily defined by not all mucinous cysts are just defined by a high CEA. So low CEA does not exclude a mucinous cyst, but a cyst with a CEA of 192 is mucinous cyst until proven otherwise. Now, a genetic test can be very helpful in that, as I mentioned earlier, a von Hippel-Lindau gene defines it as a serous cystadenoma. A KRAS mutation defines it as a mucinous cyst, as does a GNAS and a ring finger 43. These mutations are early mutations of mucinous neoplasia, but they do not correlate with grade. A GNAS mutation signifies an IPMN. A KRAS can be either mucinous cyst, and a ring finger also can be either, but more commonly seen in mucinous cystic neoplasms. And then these later mutations in the adenoma to carcinoma progression signify a high-risk cyst on its way to invasive carcinoma, usually at least high-grade dysplasia or invasive carcinoma. So these mutations would indicate the patient needs to go to surgery. Now, going back to SIS Fluid Analysis cutoff levels or CEA levels, there was a meta-analysis that looked at many different reports and suggested a cutoff level of 800 nanograms per mil. But as you can see from this table that you might have a higher specificity with 800, but you're going to pay for it in your sensitivity. You're going to leave a lot of mucinous cyst undiagnosed at that higher level. And then your amylase comes into play, being very helpful for the diagnosis of a pseudocyst. As you can see here, if it has to be above 250, usually they're in the thousands for a pseudocyst. So an amylase of, say, 100 is not going to be a pseudocyst. And also, amylase levels tend to be very low in serous cystadenomas. You cannot use it to distinguish mucinous cystic neoplasm from IPMN. So let's go back to our two questions. The first one, is it a mucinous cyst or a non-mucinous cyst? And these are the four ways we can answer that. I've gone over the gross examination, the CEA 192, KRAS, GNAS, ring finger 43, all support a mucinous cyst of any grade, does not stratify for grade, and then cytology. Now, this is an example of that thick colloid-like mucin that probably was so thick it was hard to get into the needle and therefore had to be expressed onto a slide. Your chemistry lab is going to reject a specimen like this anyway, so it really does not add anything to try to get a CEA level on this. This is a quality and quantity of mucin that is not representative of GI contamination and is representative of a mucinous cyst, and it should not be called non-diagnostic. This is diagnostic of a mucinous cyst. That answers question number one, but it doesn't answer anything else about which mucinous cyst or the grade of the mucinous cyst. It just tells you you're dealing with a mucinous cyst. Patient needs to be monitored. And then we can look in the background for mucinous epithelium. Maybe the mucin was thin and not appreciated. You couldn't tell if there was real extracellular mucin on your specimen. So then you go to look for the epithelium, and you look for epithelium that looks mucinous. You can see the mucinous compartment here, and you can see this kind of papillary architecture with this mucinous compartment. Here is more of a papillary architecture where it's rounded up and you can't see the intracytoplasmic mucin except for a few residual globules. Now, a pancreatic pseudocyst is not going to have cyst lining epithelium like that. These cysts are filled with debris and blood, old and new, proteinaceous material. One of the key clues I look for is this hematoidin-like pigment. It's grossly brown, thin fluid generally. So again, gross description, thick, white, sticky, would not be a pseudocyst. Brown, thin fluid is typical of a pseudocyst. The amount of inflammation in these is quite variable, but you should not see any epithelium like this, keeping in mind that GI contamination can be an issue. And then you shouldn't see thick extracellular mucin, and our ancillary tests can be helpful. CEA should be low, less than 192. Amylase should be in the thousands usually, and if it's less than 250, it's not a pseudocyst. Also, if the patient doesn't have a history of pancreatitis, be very wary of the diagnosis of a pseudocyst, because virtually all patients have some history of pancreatitis. And again, if you do molecular testing, you will not find mutations. Now, our serous cystadenoma has non-mucinous cuboidal epithelial cells. Our surrogate hemosiderin-laden macrophages may be all that we see. Here's an example of a diff-quick stain showing these cuboidal epithelial cells with loads of hemosiderin-laden macrophages embedded in them. Grossly, the fluid will be bloody or thin and clear, not thick, sticky or viscous. CEA and amylase should both be low, very low. And so if CEA is high or amylase is high, it's not going to be a serous cystadenoma. You will not find a KRAS or a GNAS or a ring finger 43 mutation, but you may find a hemosiderin-laden, your von Hippel-Lindau gene mutation, which can completely change the clinical impression of often a branch duct IPMN. If you have a microforceps biopsy or you have a shark core biopsy or some other type of mechanism of getting a little bit of tissue into a cell block, that may be all the difference between a non-diagnostic cytospin and a diagnostic specimen overall. Because here we can see these bland cuboidal cells that are non-mucinous. Here's our PAS highlighting the glycogen in the cytoplasm and a PAS with diastase where it was removed. So just the smallest little scrump of tissue can be sufficient to take a non-diagnostic specimen to diagnostic, because I can promise you it is very difficult to get intact serous epithelial cells in a specimen, especially when you make a direct smear. This type of a sample is very unusual to get intact, delicate, glycogen-rich epithelial cells to maintain their cohesion and cytoplasmic nuclear intactness. This was just a rare, beautiful example. In fact, these cells are so delicate that if you make just general direct smears, you may only be left with little fibrous strands of the septae, and all the cells have been degenerated. So the one place I do recommend possibly doing a liquid base for cells is a serous cystadenoma, because the cells can be floated out and preserved better than, say, direct smears. So that's question number one. Now let's go to question number two. Is the cyst a low-grade, low-risk cyst that can be monitored conservatively, which is often the case and desired in patients that are high risk for surgical resection? And we use cytology. That's going to be the best test, and late mutations can be a helpful ancillary test. And the ideal world would be able to recognize high-grade dysplasia, high-grade atypia in these mucinous cysts with accuracy. This is, and I don't know why this is so jumpy. Anyway, this is an example of a mucinous cyst with high-grade dysplasia, not yet an invasive carcinoma. And this is the perfect place to identify this risky cyst and get it out before it becomes an invasive carcinoma. Because once these cysts develop an invasive carcinoma, the prognosis is reduced in half. If you can already tell that you're dealing with an adenocarcinoma, you know, that's a shame because it probably is already invasive. When it looks like your typical PDAC, it's probably already invasive. And if you can tell it's adenocarcinoma, then that's the diagnosis you can make. We'll talk about nomenclature in just a minute. But ideally, we're going to appreciate these pre-invasive high-risk cells that indicate high-grade dysplasia and can potentially be the marker that saves the patient's life by indicating a high-risk cyst for resection. We've done some early work trying to correlate the cytology with the histology, correlating low-grade dysplasia with the typical branched duct gastric foveolar type lining. Our moderate dysplasia, again, this is gastric type that has become moderate and pseudostratified, and you can see that in our cytology. You're losing that cytoplasmic apical compartment of mucin, and the nuclei are becoming elongated and stratified all the way up to where they're tufted, losing its connection to the base, becoming rounded up, higher NC ratio nucleoli, and a loss of that cytoplasmic mucinous compartment. Now, unfortunately, it's not a perfect world, and cells become degenerated in fluid. They become rounded up. They can have a pseudo high NC ratio from degenerative reactive changes and rounding up in fluid. We have an entire network of connected pancreatic ducts that don't have borders, guards, and they can travel all through the pancreatic ductal system. So what may look like a primary 3-centimeter branch duct cyst can have connections to downstream high-grade pannin, pancreatic intraepithelial neoplasia, or other cysts that may have high-grade dysplasia. All of these cases that were interpreted as having high-grade epithelial atypia were histologically confirmed to have low-grade to intermediate-grade dysplasia. So it's not a perfect science. We've done some research trying to define the criteria for what exactly is high-grade epithelial atypia using a 12-micron duodenal enterocyte. We can compare our low-grade mucinous epithelium, which is about the same size as a duodenal enterocyte, with what we would call high-grade epithelial atypia, where the cells are smaller than a 12-micron duodenal enterocyte, sort of mimics high-grade dysplasia and a PAP, a glandular cell that has become high-grade looking. It can be difficult to distinguish them, a squamous cell from a glandular cell when they get to be this high-grade looking. So high NC ratio, scant cytoplasm losing its mucinous cytoplasmic compartment. So our three basic criteria: increased NC ratio, the chromatin pattern becomes abnormal. It's not necessarily hyperchromatic, it can be hypochromatic as illustrated here. And then a background of necrosis is also another high-risk feature. It can't be a feature that distinguishes high-grade dysplasia from invasive carcinoma, though. And that's why the high-grade epithelial atypia is an umbrella term that includes high-grade dysplasia, possibly invasive carcinoma. As I mentioned in the previous slide, if the cells already look like the typical ductal adenocarcinoma you would see on an FNA, then go ahead and call it adenocarcinoma, and it's probably a cyst associated with a solid component, and it's already invasive. Now, what do we do about intermediate grade dysplasia? Well, we also looked at a study trying to find out where was the best place to put intermediate grade dysplasia. And as you can see here, there's almost no difference between putting in the low grade or high grade category, low risk and high risk, just a slight improvement, putting it in the low risk category, and that happens to correlate with the subsequent classification or reduction in the 3-tier system to the 2-tier system for Panin. So it's now low grade, low risk is includes intermediate grade dysplasia, generally of the gastric type, and high grade atypia includes high grade dysplasia and invasive carcinoma. So here are some examples of high-grade epithelial atypia. Some of you may say, well, gosh, this looks like cancer to me. Why don't I just call it adenocarcinoma? Well, none of these were examples of invasive carcinoma. These were all non-invasive intraductal cysts with high-grade dysplasia, despite how scary some of these individual cells look. Now, how do we report these cases? When the Papa-Nicolau system of cytopathology, we have 6 tiers, and the unique component of this is the neoplastic category. In the benign neoplastic category, we include serous cystadenomas, and in the other category, we include our premalignant cysts, as well as our low-grade cysts that are classified as or described as neoplasm. The nomenclature is neoplasm or tumor. It's not cancer. Even though some would argue that these are malignant lesions, this is a tumor and this is a neoplasm. So putting it under the neoplastic category makes sense to separate it from our high-grade aggressive ductal adenocarcinomas, acinar cell carcinomas, and neuroendocrine carcinomas. It doesn't mean these don't need to be resected, but it gives the surgeon a little bit more flexibility in patient management when, say, the patient's an 85-year-old with comorbid conditions and surgery is riskier than conservative management and watchful waiting. They could die trying to remove a 1.5 centimeter well-differentiated grade 1 neuroendocrine tumor and probably would not die of that neuroendocrine tumor. So putting it into a neoplastic other heading allows that surgeon to have a conversation with that patient that their neoplastic other cytology report shows that he has a neoplasm, but one that's not positive for malignancy. It's hard to convince a patient not to have something removed that is called cancer or malignant. So that was the rationale for including those lesions in this category. So in the reporting, we can look at our 2 questions in this diagram. Mucin production is established. Is it a mucinous cyst? Is there thick colloid-like extracellular mucin? Is there cellular inflammatory debris in that mucin that can help us say that mucin came from a cyst and not from the GI tract? Is there thin mucin covering the slide that you confirmed, maybe with an extra stain or a special stain? Or is there an elevated CEA? 192 is the cutoff we use and has an accuracy of about 80%. Remember, the specificity is really high. It's the sensitivity that we need to worry about. A low CEA never excludes a mucinous cyst, but a high CEA supports it. So this question may be answered only with an elevated CEA. For example, if you have thin fluid with no epithelial cells, but an elevated CEA, you could classify it as a neoplastic other cyst, just explaining that you are doing so based on the CEA and not necessarily on the cytology. Your genetic testing later, that can also add a lot of weight and preclude the patient from having to have a repeat procedure. So even if you said thin fluid, low CEA, no mucinous epithelial cells, it's non-diagnostic, a week or 2 later, it comes back with a KRAS or a GNAS mutation, that would change the whole scenario from a non-diagnostic FNA to a diagnostic FNA. Even though your report still says non-diagnostic, the clinician will now know that cyst fluid had a mutation that defines it as a mucinous cyst. So that's the benefit of doing the molecular testing. So this 80-year-old does not need to go back right away for another test. They now answered question number 1. Then we go to question number 2. We have neoplastic epithelial cells identified. We need to decide if they're low-grade mucinous epithelium or is it high-grade epithelium, which may not necessarily be mucinous. It could be a neuroendocrine tumor. It could be a solid pseudopapillary tumor. That would be a high-risk cyst. So we have low to intermediate grade dysplasia, and we have high grade dysplasia. And this is an example of invasive carcinoma, but you can see how much they look alike. I can't tell the difference between the two on cytology. Now we look at the risk of malignancy using this nomenclature of low-grade atypia and high-grade atypia, and we can see that there's a dramatic difference in the absolute and relative risk of malignancy between mucinous cysts with low-grade atypia and high-grade atypia, or neoplastic other cysts, I should say, because neuroendocrine tumors are included in that. So there's a significant difference in these two categories, which is why it's really important that we try to separate them. Obviously, if our cutoff point for true positive goes all the way down to atypical, we improve our sensitivity at the cost of specificity. But at the level and the ancillary testing, molecular testing, to help you put all the puzzle pieces together to come up with a diagnosis that our clinical colleagues can use for proper patient management. So to finish up, I'm going to just go over one example case. So a 60-year-old female with no history of pancreatitis, important, no weight loss, no jaundice, is found to have a 3-centimeter cyst in the body location by CT scan performed due to abdominal pain. So symptoms. Slight stranding of the pancreas adjacent to the cyst is noted, but otherwise the pancreas and ductal system is normal. Stranding can indicate pancreatitis, but the patient has no history of pancreatitis. No connection to the pancreatic duct is noted. Serum lipase is normal. So this is what we see on a thin prep sample. So I don't do thin preps. This was probably a consult. So here we can see these hyperchromatic crowded group cells with almost no visible cytoplasmic mucin, maybe a little bit here. We can see that the individual cells are less than 12 microns. They have a very high NC ratio, and these cells are hyperchromatic, and they happen to be associated with background necrosis. So from the cells that we've looked at, dealing with a mucinous cyst. Amylase in this case happens to be low. Is it a mucinous cystic neoplasm? There was no connection to the pancreatic duct. It could be. It was in the body of the gland. But it also could be a branch duct IPMN. And does it matter that we distinguish between a mucinous cystic neoplasm and an IPMN? No, it's a mucinous cyst. So to answer question number 2, we've gone over these cells. These are not your low-grade mucinous epithelial cells. These are high-grade epithelial cells. So how do we write that up? Our interpretation category is neoplastic other, and our mucinous cyst with high-grade epithelial atypia is our above the line. So it's a high-risk cyst, high-risk mucinous cyst. And then you can write a note to kind of go through your thought process. A mucinous etiology is established from the elevated CEA. There was a viscous appearance on the gross inspection of the cyst fluid. This is coming from reading the EUS report. And there is mucinous epithelium on cytology. The presence of mucinous epithelial cells in hyperchromatic crowded groups, singly with marked elevated nuclear to cytoplasmic ratio, abnormal chromatin, irregular nuclear membranes, supports the diagnosis of high-grade epithelial atypia, which indicates either high-grade dysplasia or carcinoma. Again, we can't distinguish these two just on the cytology. Back to the prior slide, if it looks like ductal adenocarcinoma and you can call it cancer, that's one thing. But in this case, they're high-grade cells. It could be either one. The differential diagnosis is between a mucinous cystic neoplasm and a branched duct intraductal papillary mucinous neoplasm. We can't tell the difference on our cytology. The imaging suggests a mucinous cystic neoplasm from the absence of a connection to the pancreatic duct, the patient age and gender, cyst location, low amylase level, tends to support, but does not always, because IPMNs can have a low amylase level, but they are more common in a mucinous cystic neoplasm, although mucinous cystic neoplasms can occasionally have a high amylase level. So it's not an absolute defining feature, but surgical resection is advised based on what we see. So that's it. I am happy to take questions. Thank you so much for your attention.
Well, thank you very much, Dr. Pitman. That was very nice. It is a difficult subject when you're in the trenches, but you summarized it very, very nicely. Now, I see there are some questions coming, and we'll go over them quickly one by one. First of all, do you have any adequacy criteria for pancreatic cysts, either in your practice or in the Papa-Nicolau system published book?
No, there are no absolute criteria because we're using a multimodal approach, and I can make a diagnosis without any epithelial cells, like I said. So if I have thin, clear fluid with a CEA of 5,000, it's a mucinous cyst. If I have a acellular thin fluid with a KRAS mutation, it's a mucinous cyst. So cellularity is great if you have it, but it doesn't mean it's definitely non-diagnostic if you don't have it.
Mm-hmm. So how, if we were to sort of generalize this to other practices, and I suppose not all practices are as lucky as you are with all the, the molecular tests up their sleeve. Say you're not able to get the molecular tests like the KRAS and so forth, and you have a high CEA level, but an acellular FNA.
Yep.
What do you do with that?
Well, a high CEA would support it being a mucinous cyst. And a KRAS or GNAS mutation, well, a KRAS mutation is not going to change that. It would add support to it, right? It adds support to your elevated CEA, but a CEA, you've already made the mucinous cyst diagnosis. You've already answered question number 1 with your high CEA. Mm-hmm. So then all you're really left with is question number 2. Do you see high-grade epithelial cells or not? And your molecular testing would add support by just showing you late mutations. So if you said you saw high-grade epithelial cells, that's important. You're following the criteria, you're distinguishing them from low-grade cells. That can stand on its own without molecular testing. The molecular testing adds weight to what you're seeing on cytology, mm-hmm. or could change what you may not be seeing on cytology. So if you're not sure and all you're going to say is atypical cells, and then it comes back with a SMAD4 deletion, those atypical cells are significant, mm-hmm. and high risk. So you don't always have to have molecular testing. You can do a lot without it.
Okay. But it seems like you do have to have at least at minimum a CEA and amylase of the cyst, correct?
Well, you always have your cytology. Sure. You know what I mean? I showed you the cytology. It's just that you're gonna have a better outcome with the more ancillary tests that you have. You're gonna leave a lot of cases undiagnosed, optimally diagnosed, because you're not sure if that's mucin or not. You know, it may be thin mucin and you can't recognize it as contents of the cyst. So you are going to say, oh, thin mucin strands, no epithelial cells, non-diagnostic. So that's a non-test. But if you had that morphology with a CEA of 3000, you've gone now from a non-specific, non-diagnostic test to a diagnostic test that is neoplastic.
Correct. Okay.
You see what I mean? So it's not that you have to have these ancillary tests. It's that the ancillary tests improve our ability to give a specific, accurate diagnosis in answering those two questions.
Yes, that sounds very good. Okay, there's a couple of other questions coming in. One of the questions is, how do you distinguish gastric contaminations from the neoplasms morphologically?
Yes. You know, as I was going through this slide just now, I realized, I should have included that slide. So, because I was trying to make sure I stayed within the hour. I usually always do include the slides on gastric morphology. So knowing where the needle traversed is important. Keeping in mind that whenever you put a scope down to the duodenum, you pass through the stomach, and there is a chance you can still get some gastric contamination in a transduodenal FNA. That said, if you know that the needle went through the duodenum, you're looking for duodenal epithelium, which generally comes out in large groups and is non-mucinous enterocytes. So the enterocytes don't have mucin in the cytoplasm unless there's peptic injury. So keep that in mind. But they have a brush border, right? And goblet cells, which do have mucin in the cytoplasm, are punctuated throughout the and then you can have little intracytoplasmic lymphocytes that would be scattered throughout. So if you see those types of cells, that's duodenal contamination. Now, the tricky part comes when you have transgastric FNAs, where the lining of the stomach is gastric foveolar epithelium. And it can be impossible to distinguish gastric foveolar epithelium of the stomach from gastric foveolar epithelium of a branch duct IPMN. So that's why I was saying you had to be sure if it's lesional gastric foveolar epithelium or not. So the way I handle those cases is that if I have benign looking gastric foveolar epithelium, that's benign. It's low grade atypia. It's not high grade. So that's good, you know, as far as question number 2. But then question number 1 is that lesional and does it represent the cyst? And sometimes I have to say, I don't know, and I can't answer that question. And I put it in the negative category. But if I have or possibly non-diagnostic category, depending on parameters, or I have, let's say I have that gastric foveolar epithelium, I'm not sure if it's lesional, but I have a CA of 5,000. Again, this is where your ancillary tests come in handy, because that ancillary test is going to answer that question. It is a mucinous cyst. I'm basing that on my CEA of 5,000. My mucinous epithelium then becomes inconsequential in answering question number 1. It's now going to be consequential in answering number 2. I don't have any high-grade epithelial atypia, and it doesn't really matter at this point whether it's lesional or not, because the question number 2 is really asking you, do you have high-grade epithelial atypia that warrants surgical resection? Because you've answered question number one, based on your CEA. Do you see what I'm saying?
Yes.
Does that make sense, or is that confusing?
Yes, no, it totally makes sense to me. I'm sure it makes sense to our listeners too.
Yeah.
So kind of along the lines of that, would you ever make a definitive diagnosis of an adenocarcinoma in a cystic lesion?
Yes.
Okay, so how would you kind of then differentiate between a kind of a high-grade atypia versus an adenocarcinoma? Would it be just dependent on the endoscopist finding a solid lesion or anything else that you can hang your hat on?
It would be the morphology. Can you still see my screen?
Yes, we could see the, yes, there we go.
Okay, so when you have epithelium that looks like this, where you have, the drunken honeycomb, the lacy cytoplasm, the enormous nuclei, just this whole picture of adenocarcinoma. It looks like adenocarcinoma. You're not talking about like a high-grade dysplasia, scattered cells in the background of mucinous fluid. They look malignant. Then call it adenocarcinoma.
Okay.
And generally, I would say that by and large, these do correlate with cysts that have a solid component.
Mm-hmm. So once again, it goes back to your multimodality approach, where you actually would it would be beneficial to see the endoscopist report and add it to the ancillary testing and so forth.
But you're still looking at these cells morphologically. Right. You're saying this is cancer. This is adenocarcinoma.
Mm-hmm.
Then don't hesitate, just make that diagnosis. But what I wanted to impress was that, cells like this could go either way. And oftentimes when you see cells like this, you go and look at the report and they say, this is a 2.5 or 3 centimeter unilocular cyst, with maybe one septation, no septations, and no mural nodule.
Mm-hmm.
So, at that point, it could, from imaging perspective, it could be a low-grade cyst or a high-grade cyst. There's no high-risk imaging feature to suggest that this cyst needs to be removed. And now you're completely relying on cytopathology to grade that cyst, which can be an onerous task if, one, you don't have a lot of experience looking at these, and two, you don't have that many of these cells. Let's say, for example, this right here, most of this is necrotic material, and you're just dealing with a few intact cells that look high grade. So this is where your ancillary molecular testing could be incredibly powerful, as it would support this being a high-grade cyst. Because I showed you before that it's not a perfect world. And you're dealing with, let's say, a 60-year-old patient with a 2 centimeter pancreatic head cyst with no risk features at all by imaging, and they're going to resect that cyst based solely on your cytology diagnosis. And that's happened, for me. And then you try to sit there and say, well, it's high grade, it looks high grade, it needed to come out, and you have now a 60-year-old with a Whipple who could, have complications from that procedure. So to have molecular data that shows a SMAD4 deletion or a P53 mutation or a P16 deletion, all of these high-risk late mutations just adds tremendous amount of weight to support your diagnosis of a high-risk cyst based on cytology.
What if you have a similar situation to this case that you're showing now? You have a lot of necrosis in the background, but maybe you don't have this many cells in the background. You have a few of these cells. Where would you classify this? Would you just call this a mucinous cyst with atypia, or how does necrosis ever hold value?
Yes, it does. It holds value in putting it in the high-risk category. If all I had was just degenerative necrosis, I'd be careful. But if I had just this necrosis and I had these intact high-grade cells, I would put it in the high-grade category. Again, your comfort zone, your comfort as a pathologist in making these classifications are often weighted by quality and quantity, right? You have a lot more confidence in something like this, maybe like this, than you would in something like this, where you just have a few residual cells. And so if you were not comfortable putting it in the neoplastic, well, let me back up. You should be comfortable at least putting it in the neoplastic category. But one of the benefits of putting it in the neoplastic other category is that that is a category for all grades, and you can still classify it as a neoplasm without necessarily saying it's high grade. You know what I mean? So you're not putting it into a nondescript, non-neoplastic category such as generic atypia. Correct. You're saying this is a neoplasm, but I'm not 100% comfortable in grading it based on the quality and the quantity of the cells. Does that make sense?
Well, yeah, totally makes sense. So what would be the clinician's approach to this then if you were able to put it all the way to high grade, like, mucinous cyst with a high grade atypia? I'm assuming that it would go to surgery. What if you're not able to give it a qualifier for the atypia?
Right. Just like imaging shows you high risk features, they base a lot of surgery simply on imaging. And imaging is not perfect either. So, yes, high grade atypia is a high risk feature. But again, the benefit of saying neoplastic other over suspicious for malignancy puts it in a category where the clinician can decide surgery based on many other parameters that we may not be aware of, such as the patient's risk to surgery, comorbid conditions, age, desire. They may say, you know what, it looks low risk by imaging. The only thing that's saying it's a high risk cyst are these cytology cells. There's no genetic data to support that. I'm willing to take the risk and follow it, repeat it in 6 months, repeat it in a year. Let's see if it grows. That's an easier conversation for the surgeon to have when it's neoplastic other, even high grade atypia, than suspicious for cancer.
Sounds good.
Right?
Yes, I totally agree with you. There is one question about, could you please go over the flowchart, the triage flowchart one more time?
So,
thank you very much too.
Yeah. So number one, we're going to look for question number one. Let's assess for the mucin. Look at the gross, thick, sticky, white, opaque. Look for thick colloid-like mucin in the background, because that's kind of your low power 10x field, right? Looking at the background. Is it thick colloid-like? Is it cracking like colloid? Does the slide? Can you tell that there is truly a mucinous background? So not grossly thick, white, viscous. Then we're going to look at our CEA. Is our CEA greater than 192 nanograms per mil? It's a mucinous cyst until proven otherwise, right? False positives in lymphoepithelial cysts, which look different under the microscope, in that, keratinous debris, lymphocytes, usually they look more solid on imaging, but it doesn't give you fluid generally that can be sent well, it can be sent because you got a high CEA, but it has that epithelial lymphoid background. So rare false positive with lymphoepithelial cyst. So 192 is my cutoff. So anything above 192 is going to be a mucinous cyst. And then you can also add in your molecular testing, KRAS, to a serous cystadenoma. And does our biochemical testing support that? Amylase less than 250 and a low CEA. Again, we're already at a low CEA right here down this line. Then, are there inflammatory cells and debris, proteinaceous debris? Do you see yellow hematoidin-like pigment? Is the amylase in the thousands? That should really be present. If the amylase is really low, it's not a pseudocyst. Okay, patient should have pancreatitis. And do you see monomorphic epithelial cells, such as ones you would expect to see in a neuroendocrine tumor or a solid pseudopapillary tumor? Is the chromatin coarse and stippled? Are there coffee bean nuclei with little wispy tags of cytoplasm? The amylase is low in both of these, as is the CEA. And then if you see these cells in your specimen, let's say you might do a rapid on something like this because you're not getting really thin fluid, you could ask them to really go back to the thick wall and get more material for a cell block so that you can do your immunohistochemical stains to support that diagnosis. If you happen to send this fluid for molecular testing, a beta-catenin mutation would support your solid pseudopapillary neoplasm, and you probably won't see any mutations in the typical next-gen sequencing panel. So this would probably be negative. Then you can, if you have molecular testing, you would look for your late mutations, P53, SMAD4, P16, that would go to support your morphology. So if you see mucinous epithelium, then you need to define whether it's low grade or high grade. Low grade dysplasia, intermediate grade dysplasia, or high grade dysplasia or invasive carcinoma. Again, this ancillary testing, your molecular testing can add support to that. So that's how.
Flow chart. Very, very nice flow chart. Thank you.
You're welcome.
There's a couple other questions, and let me try to ask in order as much as I can as time permits. What if you have an FNA and you only have hemosiderin-laden macrophages and you don't have any ancillary test available?
I would put it in the negative category because you have a finding. Granted, it's technically non-diagnostic because you don't have any other ancillary tests, but you don't see any atypia. No epithelium. So I would just say negative. Cyst fluid with hemosiderin-laden macrophages, C note. And then in the note, I would look at the imaging. Is it a lobulated multicystic lesion? That morphology on imaging, tends to support a serous cyst adenoma. And you can just say in a note that although the specimen is not diagnostic, the presence of numerous hemosiderin-laden macrophages raises the possibility of a serous cyst adenoma.
So essentially, a correlation there.
Yeah, exactly. Additional tissue will be necessary, or fluid will be necessary for a definitive diagnosis. But they may not be thinking of a serous cyst adenoma. They may say, "Oh my goodness, I think this is a branch duct IPMN." And then when you say that, they'll think, "Oh gosh, this could be it can completely change the clinical impression and management of that patient just by making a statement like that."
So similar to that, another participant actually gives another scenario and asks, how do you, what is your final diagnosis if the fluid is not thick, white, viscous, and CA amylase are not available? So again, it feels like you're going to be saying negative for malignancy for this, right?
Or not diagnostic, right? So what do you have to answer question number one? Is it a mucinous cyst or non-mucinous cyst? So you really are asking, is it a mucinous cyst? Do I have data to support a mucinous cyst? Thin fluid that's not colloid-like is not definitive, so you don't have extracellular mucin. CEA is low, so you don't have that. And then you would have to rely on epithelium. So if you don't have epithelium, you don't have CEA, you don't have a gross that would support a mucinous etiology, it's going to be non-diagnostic unless you've got molecular testing. It's still non-diagnostic, but that molecular testing could save the day by finding a KRAS, GNAS, ring finger 43 mutation. So that's, again, how these ancillary tests can prevent a complete waste of time and money and effort and risk to the patient by having a non-diagnostic specimen by every other means.
So just out of curiosity then, what is your non-diagnostic rate in your institution?
What is the non-diagnostic rate? Really, I'd have to go back and look at that paper. I think it's not very high.
Okay. I mean, just because you have CEA, and my understanding is that you do molecular testing on almost all of the cases, right?
Yeah.
Yeah. So then your non-diagnostic rate would be lower as opposed to an institution if you don't have access to molecular testing or CEA, or, at the basic, if you don't have the,
Right. If you look at the papers that have been published on the clinical utility or the value of the Pancreatic system terminology, is that very thing. It takes a lot of cases out of the non-diagnostic and atypical non-specific categories and puts them into a category that at least puts them into a big bucket at minimum of neoplasia that can change patient management.
Mm-hmm. I'll ask you one sort of last question. Again, some of our participants are wondering, what would be the difference between cytospin versus thin prep? You said you don't use thin prep that often. Do you recommend one over another? And what would be the morphologic difference that you would see on these cases?
Liquid-based processing is really only advantageous when the clinician thinks they're dealing with a serous cystadenoma. So because, let's say, for example, they aspirate a serous cystadenoma and they don't get much in the way of fluid, a drop, most of it's in the needle, and very little. There's not enough for you to really make a cytospin or send for chemistry. So what are you going to do with that? Well, rather than express it on a slide and like traumatize the cells with mechanical artifact, rinse them in a liquid base, because it could rinse the cells out and preserve the morphology of the cells. So that's the only place I would recommend liquid based, because otherwise dumping fluid, like I showed you in the syringe, into preserved site or cyto-rich red or RPMI, one, it ruins the specimen for CEA and amylase. You can't do it on that. And two, it would dilute and attenuate your background information that's critical, like the quality of the mucin and the necrosis. So, and then you're only getting a representative aliquot of the cells in your slide. Mm-hmm. So a cytospin is going to spin down just about everything that's in that fluid and put it on the slide. So you're going to see many more cells. You're going to see the quality and quantity of the mucin and of carcinoma. When they're solid and cystic and big and ugly looking on imaging, that's the way they're going to look. And those are get enough material to make a cell block. When you're dealing with a 2 centimeter unilocular cyst, you're going to get 1 cc of fluid, and it's just to do much with that. So this is the kind of algorithm, tissue triage, that helps us work up that very valuable, often scant fluid for the most information that we can get.
Very nice, very nice. Well, thank you so much. This was a very nice overview of a difficult subject, pancreatic cysts. We appreciate your time. We appreciate you volunteering. And so I want to remind everybody Next week, we have actually a couple of sessions, not only one. We are going to have a session on liver FNAs. We're going to have a session on HPVs. And we also have a nice surprise for you. We're going to have a COVID-19 panel on how do people do things in their own laboratories. So watch out. ASC will be sending out information on these. So thank you very much again, Dr. Pitman.
Thank you. It's my
And-
pleasure. Goodbye, everybody. Stay safe.
Stay safe. Bye now.
Bye.